Publication of the RELY trial in 2009 has prompted a focused update of the ACC-AHA-ESC guidelines for the management of patients with atrial fibrillation. This update focuses on the use of antithrombotic agents such as Dabigatran in patients with atrial fibrillation. To summarize, the RELY trial compared Dabigatran with warfarin in more than 18,000 patients with non-valvular AF. Dabigatran was administered in fixed doses without laboratory monitoring of anticoagulation intensity. Rates for the primary outcome of all stroke or systemic embolism were reduced by 34% in the Dabigatran group, and there was no increase in major bleeding. Secondary benefits included a reduction in life-threatening intracranial and total bleeding, including lower rates of intracranial hemorrhage. And finally, there was no difference in mortality with Dabigatran compared to warfarin. What's the downside? Well, there is no specific antidote for Dabigatran, which has a half-life of about 12 to 17 hours. In addition, because of the twice-daily dosing, patients already taking warfarin with excellent INR control may have little to gain by switching. Selection of patients with AF and at least one additional risk factor for stroke who could benefit from treatment with Dabigatran as opposed to warfarin should consider individual clinical features, including the ability to comply with twice-daily dosing, availability of a program to sustain routine monitoring of INR, patient preferences, and of course, cost. Dabigatran is approved by the FDA for marketing in the United States for the prevention of stroke and systemic embolism in patients with non-valvular AF. We cannot forget that Dabigatran can still cause serious bleeding, but I think we'll be using the drug a lot in the future. It is the first new oral anticoagulant to become available for clinical use in more than 50 years, and it seems to be a winner. I'm Peter Block with a CardioSource Heart Minute.